A good day to all. Today we will be describing a case of Ewing sarcoma of the chest wall. Our patient is a 47-year-old gentleman who came to us with a right chest swelling for the last 8 months. CT thorax showed an expansor lytic lesion in the postero-inferior chest wall involving the 8th to 11th ribs. Biopsy was suggestive of Ewing sarcoma and a PET scan was done that showed no distant metastasis. After a multidisciplinary tumor board discussion, he was planned for neoadjuvant chemotherapy followed by reassessment. 4 cycles of neoadjuvant therapy, he was reassessed with PET scan which showed partial response of the lesion. So here are the pre-chemotherapy CT and PET CT images showing the lesion in the posterior chest wall involving the 8th to 11th ribs. Post-chemotherapy, the lesion had responded to involve only the 9th, 10th and 11th ribs. So this was our operative planning. We positioned the patient in the left lateral position and the incision was planned along the 10th rib. We included the biopsy site within the incision wound. We marked the anterior axillary line, the 5th intercostal space and the latissimus dorsi muscle. We planned to excise the 8th, 9th and 10th ribs en bloc and the adjoining diaphragm and to preserve the LD muscle which could be used as a flap to cover the chest wall defect. So these are the fibers of the LD muscle and these are the fibers of the serratus. So this is the direction of the LD muscle. A part of the LD muscle was excised en bloc with the tumor to attain adequate margins. So here we entered the thoracic cavity. A part of diaphragm that was excised en bloc with the tumor. We can see the liver over here, so we can proceed with our excision of the tumor with adequate margins. So we continue to cut the diaphragm and this is the lung that is seen over here. So this is the specimen excised in toto. This is the pleural surface and this is the residual defect. This is the diaphragm and the lung and the liver that is visible. So here the diaphragm defect is first repaired with proline sutures. The latissimus dorsi muscle flap is mobilized so that it would cover the region of the defect. We planned for a composite reconstruction with bone cement sandwiched between a proline mesh under a latissimus dorsi muscle flap cover. Here we prepared the bone cement. So the size of the chest wall defect was around 11 cross 11 centimeters. We prepared the bone cement to a size that is 1 centimeter less than the size of the defect, that is about 10 cross 10 centimeter. So here is the sandwiched bone cement within the Prolene mesh that is being used to reconstruct the chest wall defect. LD muzzle is placed over the Prolene mesh and sutured in place. We closed the wound over an intercostal drain and a subcutaneous vac drain as well.